So we'll start this session with the keynote address by Dr. Ashraf. Ashraf, all yours.
Thank you so much.
Thank
you. First of all, thank you so much for the invitation. Being here in India, every time I come here, I feel that the same atmosphere is like Egypt for me. A lot of friends here in India. It's more than 10 years, my friends. So let's talk. When they asked me about talk, it's IOL exchange before we go for scale fixation. So if you still have a bag, if you still have a remnant, we are going to change in a difficult situations and how to restore the pupil, because without storing the pupil, you are not going to do anything. Optically, the patient are not going to be happy even if you change the refraction of the patients. So I have no financial disclosure regarding to this presentation, but these are my disclosure to companies that I'm a consultant and a speaker to them since years and years. So an IOL exchange is rarely required. Yes, because in modern cataract surgery, usually we are meticulous in choosing the pupil in the IOL now and the site of the pupil. Owing into advances in surgical techniques, IOL design, biometry, everything was changing than the future. The future was really difficult. Nevertheless, IOL explantation and exchange are still sometimes required in certain situations. And you should know how to change. This is important. The first of these are lenticular problems, such as IOL opacification, poor neural adaptation in the premium cataract surgery nowadays, and damaged IOL. The second situation involves ocular problems, such as IOL dislocation, decentration, capsular contraction, and corneal decompensation. Or incorrect IOL power. That's rarely happen nowadays. And without iris suturing and returning the pupil size, it's difficult to make the patient happy. And when we think about iris repair in these situations, reconstruction, because you are going to reconstruct the pupil to as much as you can to maintain the pupil size. Either we go for pinhole pupiloplasty, as Ammar innovated with his group, or you do the through pupiloplasty, which is in my hand in the last 5 years the easiest way to iris repair nowadays. So let's go for the first case. I'm going to present two very nice cases. The first case, it was a female patient, 21 years old, had a congenital cataract. Cataract operation was done with an IOL implantation since 19 years. And since 8 years, the vision drops and she cannot see except 1 meter. Then after cataract, maintained more grow and captured IOL, and the pupillary membranes were seen, and the vision reached just PL with hand motion. No fundus view were seen, but the normal ultrasound photos, and the IOL was wrong calculated, taking this idea from the other eye, which also planned for exchange after this eye. So in this, always in a critical situation, you should put a plan before you go for the surgery. So this was my surgical plan. Either you remove the pupillary membrane, making the captured PMMA IOL free, removal the IOL, cleaning the after cataract, discovering if there is a still posterior capsule or not, and planning for implantation of a foldable IOL if the situation will go through. So let's go for surgery and enjoy the journey of this, because it was not an easy case. So I always think when I do that what I feel inside the eye is different than the slit lamp. These all my challenging cases like this. So with the viscoelastic, it's the best tool to feel the eye. So inject more than viscoelastic and feel what's happening inside. So as I started, I'm trying to dislodge this PMMA lens without much trauma, because it's already there is a trauma and there is a huge adhesions in the tissues. I want to reconstruct the anterior chamber and reach a good size of the pupil. So the first challenge was done, removing this PMMA with the least trauma. But there is a huge, and I discovered that the haptic broken was the cause for capture of the IOL. viscoelastic. I close the anterior chamber because manipulating the eye in a closed anterior chamber is safer for the eye. Then I'm trying to find a way or a space between this adhesion between the iris tissue and what's behind. It's amalgam. I don't know what's this. Either it's after cataract, it's anterior capsule, it's a vitreous. I don't know. Really, I don't know. So with the micro forceps, micro instrument, this is important in these cases, like micro scissor, I'm trying to create or find again the sulcus level. So it takes time, it takes time. These cases, I make it in the last set of my list to enjoy, because this is a time you cannot put the time. So I'm trying to find this amalgam. This is a huge after cataract. You can see how it's bigger, and it cannot be by AA. It's very difficult to take it by the IA. So I express it and express more, and now I can see the red reflex for the first time. But seeing the red reflex, I'm trying also to remove this after cataract. It's very difficult by the IA or even by the ocuotome. I introduced the ocuotome, but I couldn't. So I open, remove, visco expression. Now I'm dealing with the case. Now I'm seeing red reflex, but red reflex means either there is a posterior capsule, open posterior capsule, there is no bag, I don't know. So I'm trying again to find a space because I need an IOL to be placed inside. And I rarely go for scleral fixation unless I lose the bag. I do whatever I do to preserve the bag because I believe that it is the physiological place for the IOL. So I felt now that I may lose the bag, so I put my plan for Yamani, but still I'm hoping for the bag. Again, I'm trying to polish this with the ocuotome because I felt that there is no bag, very posterior capsule, but surprisingly, that it was the bag and it was the posterior capsule fibrosed. So strange for me. So I changed my hand from the ocuotome to IA. So I'm trying to remove all the cortex inside the old bag. The old bag is, I could open the bag now and removing all the cortex inside the bag. And this line is just a fibrosed posterior capsule. And I succeeded to implant single piece IOL inside the bag in this case. It was for me so strange because I planned already for Yamani. And then I restored the pupil because you cannot leave the pupil like this. I did a 4-through pupiloplasty to maintain the pupil size again to its normal level as much as I can. 4-through is the easiest way for me. I can repair the pupil easily. Take your time because don't stretch too much because it's already fibrosed iris. You don't need iris trauma to the angle. You don't need iris insertion. And this is how it looks pre-operative and post-operatively. And the patient improves a lot after surgery. The second case, it was also a weird case. It was a male patient, 28 years old, trauma since 15 years, cataract removal and IOL was done, picture of multiple peripheral anterior synechia, and with iris incarceration in angle, captured dilated pupil. The plan. Very important to put your plan to prepare your instrument. Either IOL exchange, 3-piece IOL in the sulcus, iris repair, IOL exchange, retropupillar artisan, iris repair, IOL exchange, 3-piece IOL with any method of scleral fixation and iris repair. Let's start the surgery. Again, my instrument is a viscoelastic. The viscoelastic is the best way to feel the eye inside. Still clamp something, and what inside the eye is another area or another scope. So I'm trying also to remove this very captured, incarcerated IOL in the eye. Take your time to make less trauma. So with much manipulations, I succeeded to remove it from the incarceration, bring it with cutting of the peripheral anterior synechia because I want to anterior reconstruct the eye, anterior chamber reconstruction. So more and more till I succeeded to bring the IOL outside the eye and removal of the broken haptic That was the cause of the tilting or pupil incarceration. Now I'm trying to milk the iris and also to find a space because I like the sulcus. I will maintain the bag also in spite the posterior capsule is not present. There is a vitreous. I did a posterior anterior vitrectomy for the case, but I'm trying to open a space in the sulcus because I think that I'm going to succeed to implant in the sulcus. So more and more manipulation, more and more delicate opening adhesion between the iris and the anterior capsule, you can succeed. Take your time. Don't feel that you are going to lose the case. Don't feel like this. You can do even in a very difficult cases. Now I open totally the sulcus. I succeed to put a 3-piece IOL in the sulcus, in the physiological place, and then once I finished, I will not going to leave the pupil like this. I'm trying to milk the iris to find a good tissue for iris repair. Again, with the 4-through pupilleplasty, I can take the iris in a proper way. I can take the other side and trying to restore the pupil size. And in any place in the cornea, as you all see, bring the loop and do the 4-through pupilleplasty. Again, I did here, I did the other side till I restore the pupil size of the patient to nearly a good size pupil. Finally, this is how it looks. This is how it looks before the -12 diopters. Now the patient is -1 diopter after removal of the sutures. So my take-home message, don't lose hope in surgery. This is very important. Don't complicate the way when you are dealing with a challenging case. Put all your plans in your mind before surgery. Very important. Don't raise the expectation of the patient. These cases, you cannot tell the patient, you are going to be wow. No, we are going to do the best for you, but we cannot give you hope, too much hope. Always prepare all your tools because you already planned for the surgery. Surgical techniques for iris rehabilitation is mandatory. You should know and learn successful iris repair. 4-through is one of the best tools. And always remember this. You are braver than you believe, stronger than you seem, and smarter than you think. This is how we are already, every one of you have this. But you should enrich this inside you. Thank you so much.
Oh, beautiful. Very nice, Ashraf, for the opening keynote address. I think it was very nice, especially I like the last slide.